Thank you very much and very good morning. Next 30 minutes, what I want to share with you is my experience in this area, palliative care with community participation. I've been experimenting with this concept for more than 2 decades. This is my 22nd year in palliative care. And initially, for the first few, maybe some 15 years in Kerala, and later on we have been trying to replicate and put this concept across to some other regions outside Kerala and outside India. So what I want to share with you is what have I learned. What have I learned during this process, and also the concept itself has been evolving, is still evolving. It's a very dynamic sort of concept, it's not static. And so what we were talking about 10 years ago is different from what we were talking about now. So the basic idea is the same, basic aim is the same, but the strategies, the philosophy, some of the action plans, I think we have learned during the process, hopefully. So let me start. So, no? How do we? Oh, yeah, okay, so, okay. So this is very clear. Like there is no controversy about it. Why do we need a system in the community? Because these patients need regular, continuous care, seamless care for the rest of their life, and they also need, in addition to what we offer through our medical system, in addition to what we offer as medical or nursing services, they also need regular social, psychological, and spiritual support, and for the patient, even if you have the best center somewhere in the country, it may not be always possible for the patient to come and access it all the time. So the ideal situation, the best option for the patient is to have something as close to their place as possible. And also the last point, though we are becoming more and more what we call single entities, that social capital, the willingness to share, the willingness to support is not fully lost. Is already there in most of the Asian, African, Latin American communities, and even in the West. I've done a small project in one region in Switzerland, St. Gallen, a few years ago. So this is still there. The people are still willing to, given an opportunity and given the confidence, people are still willing to help. So this is the combination of factors which actually prompt us to move into a community model. And this is some of you might have seen Jan. This is a quote from Jan. This is one of my favorite quotes from Jan. And you're saying that meaningful palliative care requires a combination of socio-economic, cultural, and medical solutions. All the three must be addressed. Not purely a medical issue, the cultural and socio-economic factors determine what kind of death we face. Today's overemphasis on medical approaches can be balanced only by people taking ownership. This again, like on one hand, we are all worried about lack of response. We are all worried about not having enough trained people, trained professionals, not having enough knowledge and skills for the practicing doctor, and not having enough money or enough medicine. And on the other hand, in a way, most of us or many of us have been trying to make the whole thing a medical issue. Death and dying are issues with other dimensions. Death and dying are not mere medical issues. And this medicalization need to be delicately balanced with something else. How do we, the basic question I think is, how do we go beyond the biomedical paradigm, at least in palliative care? How do we go beyond this nursing and medical terminology and application only? How do we see the patient as a whole? We talk about seeing the patient as a whole. We talk about psychosocial issues, spiritual issues, and all. But what do we do in practice? Most of the centers still are stuck with biomedical model. So this is something that's interesting. This is something that Jan has been saying for a long time. And simple, like a lot of problems are of the advanced patient with advanced disease are non-medical. When you take a list of, we ask the patient to make a list of the problems he or she faces, you'll see that at least 60 to 70% of the problems are not medical. There are a lot of other issues, social issues, a lot of emotional issues, a lot of spiritual issues. And so the community can play. We are exploring that. It's very clear that the medical system cannot address this properly. So we are looking at whether the community can play a role in addressing this. And we found that most of these issues can be addressed by the community. So I'm not talking about giving up the specialist centers. I'm not talking about that this specialist palliative care versus generalist palliative care. I think both are needed. There's no patient or any patient whom you see in palliative care is a potential patient for a specialist attention. He is also a potential patient for a generalist sort of care. So this cannot be either or. This need to be both. So the ideal situation would be a good network in the community, a primary healthcare system, and linked with a specialist center which can offer training and which can also take up referrals. Very often I've seen people debating this specialist palliative care versus generalist palliative care, which I think is sort of a bit absurd, because how do you differentiate between these? These are part of the same continuum of care. So this is the Stephen had also shown this slide yesterday. Yeah, this is the model that we have been following. You need specialist attention. You need people who are specialized to look after complicated issues. You give directions in medical and nursing issues, technical issues, and also act as a referral center. Then the primary healthcare level, everybody needs to do it, because this is part of the whole process of primary healthcare. Any doctor and nurse in the primary healthcare need to be, or the system need to be geared to it. And then we have the community volunteers. And again, I'm talking about the whole model. When very often when I mention community participation, people come and ask, okay, that's good. How can we get a few volunteers to help us? I'm not talking about taking volunteers as an add-on. I'm talking about a system whereby a lot of issues can be addressed in the community, and the palliative care that is being offered will not be complete unless you take up these issues at some level. And so this is the whole system that I'm talking about. The specialist care, specialist centers at the top, primary healthcare system, which is actively involved in palliative care, with active support from the community to make it comprehensive, make it complete, make it good quality care. Initially, when we were discussing it, we were talking about this as a model for low and middle income countries. But later, it was Alan Keller here, whom many of you know, who pointed out to me that the patient in the rich countries also basically require a better deal. What is appropriate for a patient in the community in the East or in the low middle income countries is also what a patient because even the best healthcare system even the richest country will not be able to provide this sort of companionship, this sort of support which is needed on a day-to-day basis. So the models, like when you talk about specialist care, when you talk about primary health care, a lot of protocols and models available, there are a lot of guidelines available, how you do it, how you train, but there is a lot of confusion on the last part, the bottom part of the pyramid. How do you engage the community? This is a question that very often is asked. There's no cookbook recipe, but there are certain guidelines, or there are things that we can probably do. So this is how do you effectively involve the community in a program is a very complicated question. Yeah. So when you talk about the community participation, we are not talking like both community and participation are terms which have been, unless you specify what exactly you mean, it gives a different meaning to different people. And people have been using these terms in different contexts. Even community participation is a continuum. It's a large range. You can have a token participation. For example, you can have a feedback from the community. You can have a volunteer at your front desk of the unit. You can have a volunteer working as a gardener or in the laundry. That's also community participation, but that is what we call token involvement. Then you can have also the other extreme. You can have total involvement, including planning. You put the problem before them, you sit with them and plan. So somewhere from this token involvement to total involvement, you have to decide where do you want to place yourself, where do you want to place your service, to what extent you want to go. All the place you stay, or when you When you involve the community in a larger scale, it has its own advantages. It has its own disadvantages also from the professional's point of view. But you have to decide on, which was just, other than just talking about community and just talking about participation, what exactly you mean is something that you have to decide. So also like, do you want people to just sit, watch, and upload, or do you want people to play? So, and how many players can you afford to take? So this is another question, because when you say there are a lot of, you can get supporters in the community, people who are not actively involved, but who sit, who fundraise or support you in the community. You can also have people who involved in decision making. So again, this is also a question, not an easy question. How many of them do you want to play with you, or how many of them do you want to sit in the gallery and upload? So this is, I'm sharing a few lessons. And this is what we have the Kerala. Kerala is my province, the small strip of land, the bottom, some of you have been there. 1% of land area of total India, 3% of population. And something very unique about Kerala is that out of 1,300 palliative care units in India, 1,200 are in Kerala. Okay, this is something that has happened over there. I'll explain how this has happened. I'll narrate it. But this is unique. This is unique from the rest of the, and it's just been, this has happened over 15 to 20 years. And so this is something, and also something, I'm not just talking about numbers. Some of you might have seen the Economic Intelligence Unit Quality of Dust Study report. Cynthia has a copy. I don't know, Cynthia, if she has a spare copy now. But 2010 and 2015, 2 reports have come out. And 2015 report was released. Both the reports, actually, when they index the quality of death, they place Kerala quite high, saying that. So this is not just delivery of services. What I'm talking about is involving the community in such a way that it affects every sphere of palliative care, including advocacy, including sort of pressure for reforms, including putting pressure on the policymakers, including putting pressure on the professional. So this is what has happened in Kerala. So we started in 1993. We started actually in 1993. We were experimenting with little patchy things for 5 or 6 years. 1999, we formally launched the neighborhood network in palliative care. 4 organizations. Again, this is interesting because only two of the organizations belong to palliative care. Malappuram University Palliative Care, Pain and Palliative Society. Alpha Charitable Society was another social organization. And Justice Sivaraman Foundation was a human rights-based legal organization. So this is a combination of four groups which actually launched the project in 1999. And the idea was to empower the community, look after the veteran patient. And also we were also thinking of evolving like I said earlier, evolving a model for the low and middle income countries. So the model that we have been trying to evolve is this one that Jan later. Actually this came much before this diagram came. Actually, in fact, Jan had drawn the diagram sitting in Calicut. With us, I remember it. So this is a network of trained volunteers in the community, a support system by trained professional institutions and organizations, and palliative care institutions and orders. This is how it started. But later on, and also like when you look at volunteers, again, this is an interesting area because people very often ask how you recruit volunteers, how you retain volunteers, so what sort of regulations, who manages volunteers. I said to them, there is no recruitment, there is no retaining, there is no management. Anybody who is interested in helping others, anybody who is interested in these areas, which practically when you explain, everybody is interested. And then we give them training. We give them training and we encourage them to work with us, but that's not a condition. We tell them that the most important thing is for you to learn how to do it. The most important thing is for you to learn how to talk to a patient. Most important thing is for you to learn how to prevent a bed sore. And this may be useful for you in your life, somewhere, in your family, in your neighborhood. So even if you don't work with us, even if you don't spend these 2 hours helping some other in the community, this is okay. Because the basic idea is to build the capacity in the community so that a lot of people in the community know what to do. So structured training. And this is the system. This is actually, again, it looks simple now, but this has evolved over a period of time. We have been experimenting with sort of some training program here, some training program there, what is needed, taking feedback. Now we have this system. This is what is we have been doing in other countries also. Half an hour sensitization to start with. Just tell them what is the problem and ask them how they can involve. So get feedback from them. And end of the session, we tell them that we have a 3-hour training program. If you are interested in learning more, you can come. So register people at that point and then take them for the 3-hour. End of the day, again, this is where we discuss palliative care. And basics of communication, what are the things that you should not tell the patient, what are the things that you should not do. And very basis of some of the wound dressing, sterilization, universal precautions, prevention of it. So then again, at the end of the 3-hour, we tell them that we have an additional 12-hour program. Those who are interested in taking this 12-hour can join us. So some of them sort of register for the enroll for the 12-hour program. And after this 12-hour training, we take them with us for some of the home visits also with our home care team. The advantage of this system is that usually if 100 people come for the initial sensitization meeting, we found that around 20 to 30 reach the final. The others drop out in between. But even the dropouts, it's okay because they go back with some information. They go back with a little bit of sensitization. They go back knowing what is happening. So and some of them may come back later to the rest of the. So this is the pattern. 100, the sensitization for everybody, then 2 stages. And once they finish the 12-hour thing, or sometimes even after 3-hour training, they sit with the patient and family. Again, we don't do any screening at the point of training. We don't ask who you are. We don't ask what are the credentials. We don't do any police check. But the family, they go back into the community, and if this is a bad person, the community will not accept. So that is a sort of screening that's happening. They find the patients in their neighborhood or in their family, sit with them. In most of the countries that where I work, there's enormous need for social support also because there are no government-run social support schemes, so very little government-run social support scheme. Social support, for example, food for the family, education support for the children. Then they help the family or train the family, teach the family in wound care, prevention of beds, so help them with some mobility. And the idea of community, they talk about palliative care. They spread the idea. And social stigma, like in many places there are social stigma. So these are the people who are active in the field. As people who over the time gain the confidence and trust of the community, they fight social stigma and they themselves organize as groups for administering palliative care locally. Advocacy, which was not our intention. Initially when we started training these people, we were looking at what sort of care they can provide in the community. But after some time we realized that this is a very strong advocacy weapon, like the tool. The way they have been working, I'll come to this point later. So this is what has happened in Kerala. In 1993, we started a single small unit. By 1999, we already had 30 community-based smaller groups, but we formally launched it in 1999. 2008, something that interesting happened. So 2008, the government of Kerala came out with a political policy. That's when we realized that the power of the sort of training and sensitization that we have been doing. When the Minister of Health, when she introduced the bill in Kerala Assembly, the Lawmakers Forum, she was surprised to find 2/3 of the legislators, 2/3 of the lawmakers, cutting across the different political parties, standing up and supporting it spontaneously. So this has happened because they knew about it. We didn't do any lobbying at all. We didn't talk even to a single legislature. So this has happened because people in the constituency, people were aware of it, they were involving in it, so they were talking about it to various other people. So this is something that is happening in the background. Once people take ownership, they push. So now then this has been steadily local government involvement and is still growing. All the local self-government institutions now have palliative care groups, now have home care programs. Many of them have outpatient clinics linked with the primary healthcare system, and community volunteers are available in all the places. So this is the sort of structure that, and then, so something that we learned over the time is that you cannot survive without, if you want to develop a comprehensive palliative care service, if you want to develop something other than just giving medicines and occasional emotional support or counseling and some nursing care. If you want to develop a comprehensive service, you cannot survive without support from the community. This is one community group celebrating palliative care day. And then our strategy has been to involve the local healthcare professionals, involve the local people, and involve the local government. Local healthcare professionals, again, initially we were talking about palliative care and compassion and all this. And then later on we realized that, okay, we are talking about good medical practice only. Because we tell them that this is only good medical and nursing practice. And also the skills that we wanted them to learn are the basic skills any clinician or anybody working in the clinical field should know. Because how do you treat? We tell them that if you cannot, it's a pity if you cannot treat a pain, a simple pain. It's a pity if you want to send somebody who is terminally ill, who has been looked after by you till then, it's a pity if you want to send them to some other person because you cannot manage that nausea. And also, if you cannot talk to a patient who is crying, if you cannot offer emotional support, that is not good for your clinical skills. So this is a sort of message that we have been trying to give, and this works because we tell them that if you do not want to work in palliative care, it's okay. But there are people who would benefit if you improve your clinical and communication skills. So this is the sort of message that short courses are offered and also longer courses. And then local people, family support, good social capital in the community. This is what we use. And involve the local government also in places where we have been working closely with the government. This has been the local government. And working with the people is radically different from working for the people. This is much more complicated and it's much more challenging and much more interesting. Like learning from them and also giving back them, sitting with them, not dictating terms. And also generating and sharing locally relevant information. We don't offer, we have a structured training program, but this is like what is relevant, what is not relevant is discussed with people locally. Then informal education, development of local groups, and change agent. There are people who are in the community who are more acceptable. To the local community, we try to get them in, rope them in, and talk to them. I'm not talking about identifying champions and putting, no. What I found that over the time was that the strategy of identifying a champion from above and dropping the champion there, it does not work. A champion should be evolving from the community. Because all the so-called champions that we identify from above, we did try doing that initially. They have their own biases, they have their own disadvantages there. But when you do this community program and a champion emerges from the community that is more acceptable to the community, that sort of people are more effective. So this involves, basically this is a capacity building. The basic philosophy behind it is that once they have the capacity to do, once they have the confidence to do, and since the problem is already there, they act spontaneously. You don't have to push them. Our idea is to always to build the capacity, professional staff, community leaders and community volunteers, and thorough decentralization. All these 1,200 units are self-sustaining units of their own. There is no central committee. Each committee is central. And then the government involvement, like we have been, when the program becomes popular, the politicians cannot afford to look away. Because this is something that is popular, this is something that is useful to the people, this is something that people appreciate. So they come to you, actually. So the ownership, but the most important thing is the ownership. It's not a program owned by you, it's the program owned by the local community. So that is the most important thing. How do you make sure that this is owned by them? And the financial issues, people always talk about funding, and once it's owned by the local community, they will find the ways. They will find the means to do it. And regular training program, and roles need to be defined clearly. What are the things that the volunteer can do? What are the things that the nurse can do? What are the things that the specialist doctor can do? This needs to be defined. And then the message that we have been trying to give is that palliative care is everybody's business. We really mean it. It's not just saying that it's everybody's business. The first photograph shows a group of policemen. After training, they decided that this is Armed Force Battalion 3 in northern Kerala. They decided that they'll use their spare time to run a palliative care service. And I think Kate had reported it in AIIHPC some time back. Interesting, because we tell them that you are also part of the community. You will also die one day. And you also come across a lot of death and dying in your. So being a policeman is not being immune. So they are unnecessary. And the other one is youngsters. I've been focusing more on youngsters for the last few years. Students in palliative care supporting a round-the-clock home care program. They raise money, they go as volunteers in it. So this is, again, this is a very well-established group in Calicut now. I think some of them have been in touch with Scott last time when they did a conference. A huge number of students involving, and having young people in the group brings in a lot of energy, lot of good ideas. And then this is a campaign that they've been running last year. Because okay, when the young people, when the students go out into the community and say something, they get more attention than say, some of us going and talking some. They say that because we care. We do this because we care. Again, when we leave it to them, we give the idea, the concept to them, and they ask them to do the sensitization program, they come up with a lot of new things which are non-conventional, which they execute, flash mobs, street plays, and that little girl, she herself is in a wheelchair, but a student, and she has been involving in a big way. Again, that was before I die, I want to, this is a campaign, the kids did the campaign in one of the shopping malls, and when a young person explained to the others why thinking about death and dying is important, that makes a much bigger impact than any of the doctor orders. So, but not rosy. This is not like when I talk about it, it looks fairly easy, but it is not easy. There are issues. Quite a lot of issues actually, and that's why many people are not involved in the community. There are a lot to say. One, you lose control. Once you decide that this is owned by the community, then you cannot dictate terms. They do. There's a certain amount of anarchy in it, which people who are not tolerant to a little bit of anarchy will be upset. And then this is that cartoon is something that would have happened if Noah had a community discussion before building the ark. So all these questions come up. Why do we need it? What do we need it? Is it really needed? Is it our priority? So this is, and somebody said that this is not a good idea. So all this will have to be contained, and then priorities differ, because again I will come to this theme, because what to talk about community is not a single entity. It has its own variation, power dynamics. Stakeholders sometimes disagree. Some people say that, okay, we should have a children's palliative care in the beginning itself. Somebody would say, no, that is, so this is and community volunteer, how do you keep the motivation alive? And when you select participants, you are biased. Depending on whom do you select? When you go to a community and when you are looking for volunteers, whom do you select? You select people whom you know, you select people who have been in touch with you, or somebody your friend knows. So there is a selection bias there. And sustainability of the program. These are our challenges. And talking about the community, you cannot talk about the community because there are so many communities there with different interests. Even in a small village, you will come across different power groups, friction, politics. So whom are you talking to? This is an interesting question. And the group may have different long-term ideologies, political issues. Something that we found over the time is that the selection of the community depends on who participates, depends on which platform is inviting them. Even yesterday, somebody was telling me that most of the volunteers come from the upper class. They don't find any volunteers from the lower socioeconomic class. Which platform are you offering? A person from lower socioeconomic class will not be comfortable working on a platform set by an upper class person or the upper class group. So if people do not come to you, look at your platform. And we have had experience with NGO platforms, had experience with religious organizations running, and you cannot expect a group of atheists to come and work on a religious. This is a common cause, but people should identify with something there. People should feel comfortable. So if you run a religious platform by a religious organization, you can expect only religious people to come. Local government platforms, political parties. And a few years ago, I think 3 or 4 years ago, we had a international workshop in Kerala, reviewing the program, and there's a time when we were training a few political party members. And there were a lot of criticism. There were a lot of people saying that these political parties will misuse it. So how can you misuse a skill? You're basically training them to look after somebody who is better done. You're training them to look. So as long as you keep the doors open, as long as you don't specify, as long as you're not biased towards any single political party, this is also open. So I'll finish in 2 minutes, 1 minute. And then the district administration. So of all this platform, district administration is something that we have been experimenting recently. And of all the platforms, we have found that the district administration platform is more neutral. More neutral. If you find the district administration interested and committed, so again before that, like the NGO platform, we have experimented with in Kerala, Tamil Nadu, Pondicherry in India, Jakarta, Indonesia, northern Jakarta. Now we are doing the last few months, 1 year. We have been doing it with it. Sri Lanka is again an NGO platform. Religious groups, Kerala, Christian and Muslim religious groups were actively involved. Uttar Pradesh and Uttarakhand, Hindu religious group been involved. Local government in Kerala have been involved. Political parties, I don't see it anywhere else, but in Kerala, political parties have been involved in a big way. District administration, we have been experimenting in West Bengal, rural West Bengal. 2 districts, Nadia and Murshidabad so far, and the 3rd district is coming up now. So I'll just look at this last one. Because I have a bias towards it, because I found that this is much more, if it's possible. Because the identification and mobilization of resources is easy for them. Linking up the government machinery with the civil society is easy for them. And sensitization from their own departments, support and in-house training. And this is more neutral. District administration is neutral. If they show interest, that is the most neutral platform that is available. So this is all that I have to share. I don't know if you agree with all the things that I said. It's unlikely. You may not agree with many of them. But that's okay. That's okay. But this is my experience. This is what I learned. And happy to share with you. And I'll be happy to take any questions after the discussion that is suggested. Thank you.